Okay, I think that as I started, like, good evening, everyone. I'm just going to give a minute or so just to let the participants in and let the numbers start to increase. There'll be a few there's always a few stragglers and a few latecomers. I'll start by obviously saying hello. And we obviously live in quite strange times just now. And there's been a lot of very good CPD put on during these last 6 months when everybody's been in lockdown. And I think everybody who signs up or comes along or spends an evening doing it is to be commended. And those who put CPD on during these challenging times also is to be commended as well. I'm aware that this is a multinational audience where we've obviously quite a lot of French people watching. We've got probably a few from the rest of mainland Europe, a few Scottish, a few Irish, a couple from America and Australia. I obviously have sometimes quite a thick accent and can, as is my way, speak quite quickly as well. It's a slightly Scottish trait. So I will do my best to be as clear and succinct as I can be. And I will also try and slow down if I have to. So the numbers are rising. So I'll probably give it another minute. So if everyone wants to go and get a drink or a coffee or anything last minute to eat, and then we will get started. Within this presentation, there are quite a few videos with all these things. That the hope is here the videos will work and we don't have any technical glitches, but you can never guarantee these things. So please bear with me if we have any technical glitches and you have to sit and watch me kind of fiddle around on the computer trying to get videos working on the screen right. But fingers crossed we don't have any issues, but you can never guarantee with sharing a screen as well as sharing it through Zoom also. Right, so I think we'll get started. So we're going to have a wee look at the Achilles tendinopathy, and I've titled this The Clinical Journey. So my name is Kenny Watt. I'll give a quick brief introduction to who I am. So I'm a consultant physiotherapist and director of Project Physio, which is a clinic here based in Scotland. I've been in private practice for 9 years. Before that, a couple of years in the NHS here in the UK. I've been the lead physiotherapist for Scottish Volleyball for 11 years. I've done 4 World University Games as a physio and deputy head physio for Team GB and Team GB students. And I'm due to be the deputy head physio again in 2021 in China, but with all things up in the air, what will go ahead. In 2014 at the Commonwealth Games, I was lead physiotherapist for athletics. In the Commonwealth Games in 2018, I was a Team Scotland physiotherapist for beach volleyball, weightlifting, powerlifting, and basketball. And my Twitter handle's at the bottom there as well. These slides will get sent out to everybody as well. So feel free to take notes, but the slides will come out also. So what are our goals and aims for today? So we're going to have a look at the clinical journey of Achilles tendinopathy, and we're going to have a little look at the treatment as well. We're going to run through the current evidence, what evidence we have for the interventions that we use and we might look to apply. We will then go on a bit of a clinical journey of a patient, and this is where we're going to use some of the fantastic equipment from Convent and look at how I use some of their equipment within the treatment of Achilles tendinopathy, and we'll look at some monitoring, a bit of testing, and then also what we do from a rehabilitation standpoint. I'm going to stick mostly to mid-portion Achilles tendinopathy. There's obviously huge amounts of pathologies around Achilles tendons, insertional, and I'm going to mostly stick to sort of active population. Again, there is a wider conversation and probably a whole day's course, not 2 days course, looking at the various strains of Achilles tendinopathy, but we're going to stick mostly here to an active population. That's largely because it's what I see an awful lot of, and it's probably largely what a lot of people see out there. I'm a clinician. I'm not a biomechanist, and I'm certainly not an engineer. I'm not even a researcher to some extent. So there'll be some parts here, maybe some questions you have that may be very biomechanically based or engineering questions about the equipment, which I am not in any place to answer. And they are questions that you may want to then follow up with the guys at Convent along. Within the presentation, there's quite a few QR codes for you to be able to access papers and bits and pieces. So if you have a phone ready, you might want to get that ready to be able to scan those QR codes. So let's get started. So who is on this journey with us? So Achilles tendinopathy, we see it very much in an active population. That active population very often is potentially could be those in their early 20s and their late 20s. We see it also in a population who are maybe 30s, 40s as well, who are maybe returning to exercise, say after having family or having been active when they were younger and then taking time off. We see it in those who maybe are looking to lose weight. And right now, in the world we live in, we're seeing an awful lot in those who have taken up exercise because they are now working from home as well. So very much an active population, one side of it. And then we also see a sedentary population. And that's very often in those in 60 plus, very often caused sometimes by lifestyle factors. Potentially they are, as I said, the words they are sedentary. We may see them have metabolic disease, other health conditions which impact upon their tendons. They may also be returning to exercise as well, but at this stage we might be into the world of disuse or some atrophy also. So two very different populations. As I say, we're going to focus probably more on the active. It's the most commonly reported injury we see in runners. Non-elite general population runners in the UK, there's a point prevalence of 44% and a lifetime prevalence of 57%, which is huge numbers and quite astonishing numbers when you actually start to think about it. That half the runners out there at some point will be struggling with or have some symptoms of Achilles tendinopathy or have had Achilles tendinopathy. In the elite long distance runners, we also have a lifetime risk of 52%. So really, this running population, be it non-elite or be it elite, it seems to strike them all at some point. It's not purely an athletic injury. So 65% of Achilles tendon injuries diagnosed in a general practice are not sport related. And this is a study out of Holland. Difficult to take these numbers, to really know what to do with these numbers, because these figures were taken from looking back over general practitioner notes or doctor's notes. And doctors may not have asked what sports, what the background was. A lot of these runners who may not actually seek out GP normal care, they may come and see, say, private physiotherapists or physical therapists instead. So my instinct and my clinical impression would be is that, well, it seems a very high amount of people to get Achilles tendon injuries at 65%. My instinct here would be is that probably that isn't as high as that, and probably some of these people were active alongside or active in some form. So let's have a look at tendons. I'm not going to go too deep into pathology as such. So tendon cells respond to strain, and that strain can have positive or negative effects. For a long time, we thought tendon cells were kind of metabolically inactive to some extent. We've seen a number of studies now come out to say that they have some metabolic activity ongoing. That activity is slow in comparison to, say, muscles, but the fact it is metabolically active, but very low level or slow level, means it's quite beneficial for the tendon because it allows it to carry loads and maintain tension over a long period of time without the energy inefficiency. As I say, that strain can have a positive or negative effect. What we see sometimes in the negative effect is that actually that metabolic activity increases when the tendon becomes tendinopathic, which very often explains any sort of change in structure, change in size that we see. With this increased activity, we might see increase in cell size, increase in cell number, and then that may start to bring more fluid into the tendon. And so that increased activity, we then will see as this change in form to some extent. What we don't know right now is where the tipping point is between what is positive and what is negative. And hopefully we'll get a better, clearer idea of that in time. What we do know, though, is that the loading of the tendon seems to have a role in the strain that goes through it. So we see it within the intensive trained endurance athletes seem to have an increase in cross-sectional area. We also see it in resistance trained athletes who also, again, have this increase in cross-sectional area. And we also see an increase in stiffness and size with lower numbers of loads of long durations, so 6 seconds or so, 6 seconds plus, compared to then a higher number of loads of short duration. Now, cross-sectional area isn't the kind of the be-all and end-all. We will see other changes ongoing with kind of chronic loading or long-term loading of tendons as well, and we can still see performance improvements. And there's studies looking at runners who improve their times and performances over a season, yet we don't see any change in tendon size as such. So cross-sectional isn't the only thing, but it does seem to be a way we measure the impact of loading on a tendon. So what brings on this adaptation? Now, this is a chart we see an awful lot in a lot of presentations. So we know that exercise increases synthesis, but also degradation of collagen in human tendons. So if we look at, let's see if I can get my pen up. So if we look at this point, post-exercise, 24 hours after, if we look at the purple line here is the net synthesis, so the net collagen change. The line above is the synthesis itself, and then the line below is the degradation. So we see around about 24 to 36 hours that actually we're in some loss post-exercise, and then it starts to change. About 36 to 72 hours, we start to move into a higher level of collagen, a higher number of collagen, and then as it starts to then level off, that we then end up with a net gain overall. The important thing about this chart is we use this chart an awful lot then to be able to guide patients and instruct patients on safe kind of recovery periods or rest periods when we're trying to treat tendons. However, the thing with this study is to remember that this was done on trained runners, 7 trained runners who had completed about 30 kilometers of running. So these were high-end exercisers, and that 30 kilometers were the longest exercise they'd done. So this is a great chart to use, and when we see second, third, fourth opinions on tendons, it's very often they've been given information around about this table. The important thing to remember is this will not be the same for everybody. Many things might interfere with those two lines. Slow healing might impact upon it. Poor collagen may impact upon it. What we think may happen as well as it in time with athletes is that actually it's the amount of degradation that happens changes as we go along. So as they continually load via training, the collagen synthesis continues to go up. And while in the early stages of training, the degradation matches what we see in the chart here, but then actually that degradation may start to reduce a little bit. So we end up in net gain of collagen is what we think may happen. So where does it go wrong, and why are we here? So we're here because we want to talk about tendinopathy. So tendinopathy is described as either degeneration or failed healing due to continuous overload without appropriate recovery. So in essence, people are not giving themselves enough time after exercising to allow this synthesis and degradation and this change of collagen level for the repair phase to happen. And we may just not have enough appropriate recovery. So we now have an imbalance here of the wear and the repair, where the wear of the exercise, the walking, whatever it is, the activity or life in general, against the amount of time we have for the repair to happen alongside. And it's this imbalance that we're interested in. So which path do we take? So load capacity has been defined as being able to perform functional movements at the volume and frequency required without exacerbating injury or causing tissue injury, which is potentially mediated through changes in tendon properties or kinetic chain function, or really in essence just life. So life is going to shift our load capacity. So what we can see in it's a really lovely table that from Sean Docking and Jill Cook is it gives us an idea again of there's an increasing load, what happens against the amount of cyclic strain, so the strain that we talked about already that is applied onto the tendons. So with the right amount of strain applied, we will live quite nicely in this adaptation or homeostasis sort of window. And that can move between a few different levels of cyclic strain. If we then start to increase that strain just a little, then we might start to again get some adaptation. But if we increase it far too much too quickly or over a period of time, we may then get this maladaptive response due to kind of overstimulation. We'll see some inflammatory cell markers start to show up. We may start to see some cell death. the other side is also true, where we might then see understimulation. So those who don't use their tendons, those who are very sedentary, where will then the graph will shift and we're not getting enough strain for positive change within it. And again, we may then see a change in the type of collagen that shows up in these tendons as well. So a slightly simpler chart then, what we have is the ability is that this line, the yellow line that we can see, the yellow line we can see here, if that line may then move and shift and change over time. So if that is our level of exercise we're doing just now, if we start to ask a little bit more, but slowly over time, bit by bit, adding more load, we may adapt the tendon at that stage. That tendon adaptation now means that those strains that we were applying before are now no longer overloading, but that now give us our adaptation we were looking for, this increase in cross-sectional area, this increase in stiffness and in tendon health. The opposite may be true, where we may then see a shift backwards, and it may then take us in the other direction, and that may come through becoming sedentary for a short period of time. It may come through injury, it may come through being on holiday, it may come through having time off from exercise. So this is a very kind of sort of fluid and dynamic situation where this line will move backwards and forwards, and that may then have an impact on the chart we looked at before when we looked at the synthesis and degradation, because that will only ring true depending on what stage the tendon is at that moment to some extent. And so we're going to always want to know how much force are we applying, and are we lying currently in that adaptation homeostasis area, and if we want to train, how much can we ask to start to move that line to the right hand side. So let's have a little quick look at pathology again. So the presence or extent of structural disorganization is not critical in determining the load capacity or if the person then gets pain from this tendon. So this structural disorganization, this maladaptive that we looked at just a second ago, this maladaptive situation we might find ourselves in, doesn't mean that it determines that load capacity or if that person's going to arrive in pain. But with maladaptive response and that failed healing, we might get some pain along the way, but we can't always necessarily link structure to pain with tendons. Some people will on scans will look as if they have quite bad looking tendons and have no pain. Others will have huge amounts of pain and actually not see a great amount of change in the structure itself. But once we do have some pain though, it can be associated with abnormal tendon structure, reduced load capacity and decreased performance. And that can be true for the whole kinetic chain. So that now all of a sudden this tendon is not able to have the same amount of load capacity, and we might start to see a performance dropping off. A clinician's primary concern then is how can we improve load capacity in that pathological tendon. So it's important to know that we're not only then just thinking about what maybe tissue level changes, but person level changes as well. And this is something, a phrase I've taken from this Docking and Cook paper, where they talk a lot about this tissue level, so in essence the cells themselves, and the person level changes may be in terms of performance and so on and so forth. We're going to expand that out a little bit and think a little bit about person level being the individual as well as the tissue level. But it's important that we're going to try and aim to see a difference in both if we're going to be successful. So let's now have a little think about where do we start. So every journey has a beginning. So what does history tell us about treating tendons, and what did the evidence actually tell us? So my experience way back in the NHS when I started was that anybody walking in the door with an Achilles tendon was almost standardly given out the Alfredson protocol, so the eccentric off a step protocol. It was the given standard one that everybody got. I mean, use the phrase of a stick on the kettle, it's Achilles tendon, because our assumption was this works. That was largely because this was in the early days of kind of evidence-based practice within physiotherapy, where we were seeing the odd paper coming out, which then would just spread, and everybody was applying the same techniques without necessarily always looking whether or not the evidence was really there. Stanish in the 80s had looked at this previously, but Alfredson was the first one that really expanded it out. We will probably all know the protocol quite straightforward. 3 times 15 with a knee bent, 3 times 15 with a knee straight off a step, and that was done twice a day. That works out to be about 180 reps a day. That was a 12-week program, and the amazing thing with this study was that 100% in that treatment arm got better. Their pain significantly improved, and they all returned to running. But what was important to look at the study was that there was only 15 participants, 12 men and only 3 women. They were almost all in their 40s, and we only actually saw a 10 to 15% improvement in their plantar flexion strength, yet a lot of them had upwards of 40% reductions in plantar flexion strength. So a great study, and a huge amount of people got better handing out this protocol, and it's still handed out this day. But we want to just start to see is that was the beginning, and how have things changed as we've gone along. So as I say, this was an important study. It told us that exercise did work, but in a very small cohort. But we want to know is what other options are available to us to bring about this tissue level and person level change, and how do we get them to the end of their journey, and how do we know that they've finally arrived at the end of this individual's journey. So where are we now in terms of eccentrics and the current evidence? So Murphy in 2019 did a systematic review and meta-analysis on the efficacy of heavy eccentric training for treating mid-portion Achilles tendons. 6 exercise interventions have been reported, and the review looked at 7 studies. It's what it found. It found that heavy eccentric training may be better than wait and see and traditional physiotherapy for mid-portion Achilles tendons, but the quality of the evidence was very low and low respectively. Other exercise interventions such as heavy slow resistance training may be superior to heavy eccentric shaft training for mid-portions of tendons. However, again, the quality of the evidence is low and the difference is unlikely to be clinically significant. The other current evidence now shows which treatment is most effective for patients with Achilles tendinopathy. A living systematic review with network analysis of, again, 29 randomized controlled trials. This is an open access paper, so again, the QR code is there if you want to scan that, and that will take you to that paper. They looked at 29 trials, looking at 42 different treatments. In the analysis of the trials, wait and see was not recommended, as all active treatments they looked at were found to be superior. And given the large uncertainty in comparative estimates and risk of bias in studies, no specific treatment can be recommended over another. But within the conclusion, we see is that exercise therapy is easy to prescribe, can be of low cost, and has few harms. Clinicians should consider starting treatment with a calf muscle exercise program. To expand this out into looking at then the other evidence that we have, or other treatments and adjuncts we have, taken from DOSBT, but produced in Silbernagel's paper. We have the strength of recommendation for exercise. So again, exercise comes out with an A, with the strongest evidence in support of effectiveness in reducing symptoms. And we can see the others, orthotics in there, the B, laser therapy with a B, taping with a C. So it gives us an idea of really where does the evidence lie currently, and it strongly would indicate that it lies currently with exercise, with the only other one coming alongside injection therapy, but not done alone if it's combined with exercise therapy as well. So the path seems pretty clear. I'm going to use exercise, and why? Well, because people do get better. If we look at it again in our systematic review, this time from Murphy, we looked at loading protocols, and we see that within that, some improvements in pain and function occur as early as 2 weeks following the inception of a loading protocol. 12 weeks following the inception of the loading protocol, the participants' visa scores can be anticipated to improve by approximately 21 points. And when we look at visa scores, well, the clinically important difference in mid-portion Achilles tendinopathy is round about 10. So people get better with this. The exercise seems to have quite a nice impact. So again, the path remains looking pretty clear. But when we look at the diagram on the right-hand side, it doesn't look too clear. Chang and Kulig in 2015 provide a really nice insight into the change in mechanical properties and the muscle-tendon interaction and the impact on the central nervous system. What this little graph shows us, or this diagram shows us, is that this is a whole body experience. This is not just simply down to one tendon. We may see this degraded mechanical properties down here, and the morphology change. That may then change the level of activity within the muscle itself. We then get up into our central nervous system control, where all of a sudden the feedback control is slightly off. We might see some altered feed forward control going down again into the corticospinal tracts. And we may see a change then in muscle activity with decreased agonist activity, increased synergist activity. So we're going to see a whole body effect here, where we might see muscles starting to fire at different rates. We may see a change in tone. And again, we're going to have to take this into consideration when we look at our treatment, is that we want to approach this as a whole body experience, taking into consideration all the changes we may see. We also, while exercise comes out with an A in terms of it as an intervention, the evidence still remains quite low, and the papers are very often at risk of bias. And then ultimately on top of that, we also see this systematic review from Murphy that found that 24 studies, only one found that Visa A scores at the end of the loading protocol had a score of above 90 points. This would indicate that there's still ongoing pain and reduced function in a lot of these patients. We also see that around about 60% of these patients may have continuing symptoms. 40% may have to go on to have contralateral symptoms, and 50% of our patient satisfaction is moderate to poor, with a 27% recurrence rate. So these seem really poor outcomes in the long term for some of these patients. The studies reviewed clearly show that there's large deficits in strength between the subjects with and without Achilles tendinopathy. These deficits are apparent across the full strength spectrum and in all knee positions. They conclude that one possible explanation for such poor results may relate to the altered strength profile or the persistent weakness due to Achilles tendinopathy. So these patients are showing themselves to, well, they may be showing improvements within, say, the 12 weeks of some of these studies. Actually, the long-term outcome for some of these patients isn't always going to be fantastic. They may struggle further down the line, a year down the line, 2 years down the line, the study's looking at 8 years down the line, and still finding patients that are having difficulties. And really, it's going to be a question of where are they falling down and why are they not seeing an improvement. So if we're saying they're weak, how weak actually are they? So quite a busy slide, but in essence, what we're seeing is that the strength deficits are, as it says, across the spectrum. So we're seeing that maximum strength profile is down in some concentric peak torques, eccentric peak torques. We're also going to see that isometric strength has some deficits also. Isoinertial strength also down, and then we have an explosive strength profile. So we see deficits of 10% to 21% between symptomatic and non-symptomatic. Our hopping, we also see some deficits too in single-legged hopping distance, triple-legged hopping distance. On the right, the two little graphs come from Seth O'Neill's PhD, looking at gastroc and soleus. And what we can see is that if you look at the greens, initially the green line is the control group, and the concentric force and the eccentric force, and the same again underneath. And we see the Achilles tendinopathy group, who start off on the blue as already weaker than the control group. And then after 12 weeks of a program, which again followed quite closely the Alfredson protocol, slightly adapted, we see these numbers again increased, but they still remain down, both against the control, both in soleus and even in soleus and in gastroc as well. So these 12 weeks of exercise have improved these patients, but they still remain far away from potentially where they would be in the control group. So how are we going to get them stronger? What do we want to prescribe? What do we want to start to think about? Well, we're going to probably look at a kind of top-down and bottom-up approach for this. So if we start with bottom-up, we're going to want to look at potentially using heavy loads. We've already seen from systematic reviews that looked at some of these protocols, eccentric protocols, that very often they start off with body weight and they may start to only see small incremental increases. If we consider that within 2 weeks, if we start seeing improvements in 2 weeks, 4 weeks, 6 weeks with body weight exercise or small incremental exercises, then people may stop these exercises after a period of time because they feel better. But that may then leave us with strength deficits across the spectrum. Heavy loads may be superior to increase the tendon mechanical properties. It makes tendons stiffer, i.e. so the tendon strains less under a given load. With a wider cross-sectional area, we can spread that load a little bit more. If you apply heavy loads slowly, as in a heavy slow resistance regime or a heavy isometric load over a number of weeks, the tendon will adapt. The systematic review by Baum in 2015 found that loads of more than 70% MVC for isometric and 70% of 1 rep maximum for isotonic, that was applied for long enough, over 12 weeks, we then see this lead into tendon stiffness adaptation. Caveat for these studies, for the Baum studies, is that this is all in healthy tendons. So what we need to know is, can we apply similar rules to pathology? And there are some really nice studies that have looked at heavy resistance training, or a heavy resistance training program, which is maybe 3 or 4 exercises done over a few days, looking at changes within patella tendons especially. So why specifically for Achilles tendinopathy does it have to be heavy? Well, again, when we look at the forces that are transmitted through Achilles tendinopathy, so look at Seth O'Neill against his studies, we see 200% body weight and eccentric torque can go through this Achilles tendon per second when running. We know that round about 4 times body weight will go through it with walking, 6 to 8 times body weight potentially with running, and then jumping right up to 12 times body weight with sprinting and jumping. So these are huge forces where a body weight calf raise or very small amount of weight added to a calf raise is just not going to cut it to recreate or put the amount of force down to this tendon that we're going to be looking for to get adaptation, or to bring the tendon back into being allowing for improved performance or return to performance. So we may want more than just some heavy loads for this journey. So prospective studies have shown that degenerative tendons have a limited ability to normalize, and what changes we do see don't always carry over into clinical improvements. So people may get strong, but they may then not still find that they're getting any different or changing at all. And Pete Maliaris did a systematic review to try and work out potentially what is it that changes in these patients. And one of his conclusions was that it's the only potential mechanism that was consistently associated with improved Achilles tendon rehabilitation was improved neuromuscular performance. And the literature seems to support this notion that in mid-portion, the deeper surface of the Achilles tendon, which is linked into soleus, undergoes the greatest displacement, and this seems to be where we see most tendon changes. So in this deeper section of the Achilles tendon, that's heavily made up of the soleus muscle itself. And again, looking at some of Seth O'Neill's work, we seem to think that soleus may be the muscle between gastroc and soleus that shows the greatest loss of force generating capacity. And if we just look at what soleus can do, if we look at the chart on the right, coming from some of Tim Dorn's work, if we look at the speed of, say, 3.48 millicentimeters per second, which may be walking or fast walking, all the way up to 8.99, which may be running or sprinting, the force production out of gastroc in comparison to soleus, the soleus not only walking is doing a huge amount of work, but as we start to increase into sprinting, it's also still doing a huge amount of work. So it's a muscle group we can't afford then to ignore. We also have some evidence emerging that specialized regions in the tendon exist, with some parts known to facilitate energy storage and other parts probably looking to facilitate strain gradients. So these two muscles, the soleus and gastroc, may sort of work separately. The two parts of the tendon may also work separately as well. And we may see that, we may want to consider that when we think of the type of patients that we see. So if we have patients who are very springy, who do a sports with a lot of athleticism, we're going to want to work on soleus, but we might also think about we need to think about the energy storage, where we might see patients again in the kind of older population who are just interested in walking, and how do we access the parts of the tendon that are maybe more interested in the kind of strain gradients. So if there's two separate parts of the tendon and two separate muscles, does the issue of motor control and coordination become pertinent to what we're going to try and prescribe to these patients, and how we're going to put together a rehabilitation program? So we also have considerations, again, a little bit about what do we mean by coordination? What do we mean by neuromuscular control? And one school of thought about this change in neuromuscular control, or if this is what's potentially making the impact on a lot of these patients, is that the muscle tendon unit functions as a shock absorber and a spring. If we have good muscle coordination, we're going to have really nice increased energy efficiency, really lovely elastic recoil. less heat production, and they have the potential to improve or protect from tendinopathy, potentially by maintaining good calf strength and good muscle tendon unit function. If we have poor muscle function or coordination, what we see, or what's theorized to see, is we may see these small oscillations in the tendon or in the muscle, and fluctuations in the force. And that is described, and you see it in patients sometimes when going through a calf raise. If they really shudder in terms of control, they may look great going up in their concentric phase, but in their eccentric phase, you may see this sort of shuddering effect or this slight lack of control, or they'll just come down very, very fast. And that might start to indicate they have some poor coordination. Very often, if you ask patients to do a calf raise with their knee straight, they may do it fine. If you then slightly impact upon their knee position and ask them then to lift their heel off the ground, that slight shift in knee, a bit more knee flexion, may then throw them off, and they can't quite coordinate that movement. This might then lead to some reduced energy efficiency, greater energy absorption, but producing more heat. This heat might then have a role to play in producing their cellular response and then causing some tendinopathy. And then we start to see again this increase in amplitude of more increased tendon strain and greater cumulative load as well. And this again, some really nice work from Seth O'Neill, one of his papers looking at this. So again, we're going to think about our heavy loads. We're going to start to think a little bit about our strength and neuromuscular coordination. And so this might then start to put together the kind of stages that we're going to think about, or what might make up the building blocks of our program. We're going to want to have some strength and neuromuscular control in there with the aim to increase the strength and the kind of coordinations and pathways. Why we're going to do that? Well, we looked at that in the heavy loading slide. We may look to isolate the exercise out, because isolated exercises for calf, for soleus, for gastroc, for the tendon, they've been shown to impact most on musculotendinous unit mechanical properties. So single joint loaded exercise might provide us with that greatest opportunity. How might we prescribe these exercises? Well, we're going to want them to be hard to lift on both legs, and that might be enough of a rule. Is that if you prescribe to these people, you might give them a weight to lift, their body weight. If they find that hard, that might be the right weight for them. If they find it very easy, we might just simply find a weight that they describe as being difficult. We may use our pain monitoring tools or an RPE scale to get an idea again of just how hard did this find, and we'll come back to pain monitoring later on. Some people use the amount of body weight. So in seated, we might use 1.5 times body weight, standing 0.5 times body weight, in leg press machines sometimes for soleus or Achilles as well. So varying levels of force that we can apply. Bayer looked at this in their study, looking at 3 times a week, and again we saw 3 times 15 repetition max, and then that would build and build as the weeks pass into 4 times 8 repetition max, and that, I say, was done 3 times a week. We may look at also some plyometrics to get some stretch shortening cycle work into it as well, some explosive work. I would direct you towards the work of kind of Igor Sancho, who's looked a lot of this, starting to apply plyometrics into these programs, and it's looking at a jumping, hopping program as well. The aim here might be to increase our maximal rate of torque development, increase our voluntary contraction, increase our jump and our hop performance. And we may use a little bit of jumping and hopping to try and desensitize tendons as well. Very often the hopping and jumping is the thing that concerns or worries patients the most. And if we can gently encourage them to start to do some hopping or jumping, and as long as we're guiding it by pain, it can very often desensitize or reduce people's fear. We also saw that the deficits show up in this sort of stretch shortening cycle. With explosive activities, and so we're going to want to apply some sort of exercise intervention to have an effect on that. It allows us to put peak loads in, but maybe without high cumulative loads that we see through running or hill walking. These plyometrics, and again, if we look at Igor's work, hopping side to side, hopping backwards, by changing direction, we might also increase the amount of work coming from other ankle musculature as well. And for some patients as well, who don't ever really do any sort of explosive exercise, it can be a really lovely novel stimulus for the central nervous system, and really light up the brain and really give them something new to try. And again, if guided and controlled, can have a really lovely impact on outcomes as well. For the dorsage, we might look at athletic population of when they can do a single leg raise with 20% body weight, but we're never likely going to be too many. We're always going to be a little bit cautious in just in terms of how much we apply as well. So if we also want to think about this, we talked about bottom up. Let's go from top down a little bit and look at education. Patients with Achilles tendinopathy face fear and uncertainty regarding tendon pain and may be concerned about damage, and this may influence their adherence to rehab and loading programs. So when we look at these patients, tendinopathy, especially in chronic long-term tendinopathy, or even in new tendinopathy, and maybe it's an athletic population who are looking to perform, can be hugely worrying for them and can really have a big impact on their everyday life. They may have a sense of a loss of self. They may have poor treatment experience. Very often we'll find that these patients have been through 3 or 4 physiotherapists. They may have lost a little bit of trust in the treatment process as well. They may have their beliefs around about what caused it might also not be tie in quite correctly. They may use rest almost, or may have been using rest almost exclusively as a management approach. They may have fear about how it's going to, what the long-term prognosis. So Turner did a really lovely study again where they interviewed patients again with Achilles tendinopathy. And we see that some biopsychosocial impacts. We see some, again, the prognosis and outlook, experience with management, and some of the phrases and words that the patients use that I feel like I don't know more, but I don't. I say I should know more, but I don't. It's disappointing and pretty frustrating going through the treatment. People can see themselves as being better. I no longer feel like I'm in control of it now. So, really quite strong phrases that, again, we really want to take into consideration when this patient's sitting in front of us, of just how may they be feeling, how may we be able to impact on that. We use the term very often, pain education. Again, with these patients, we want to be quite careful about the wording that we use. And I think it's important that these education sessions show up very early in the treatment approach. So we will use it in the very, very first session to try and get patients on board. We want to try and get a cognitive response from these people by challenging their understanding. What do they really understand about what brings them there? What do we really understand about the pathology? As I said, we may try and use some of our language and education to sort of desensitize the situation, try and go through the process of explaining that the hurt may not equal harm, so the tendon may be sore, but actually that may not be that there's doing any damage to the tendon whatsoever. We may want to go through the process of explaining pain and stiffness, what may be causing the pain, what may be causing the stiffness, and explain that the pain doesn't necessarily always mean that they're going to have reduced capacity. They may still be able to perform huge amounts of activity with some pain alongside. And again, we may want to demonstrate objective change. So again, we may be able to say that, okay, on the first session, this is all you could do, but 10 sessions later, look at what you can do now. Yes, there might still be some pain there, but your capacity has changed. And that, again, may be a lovely way to get some patient buy-in. We really want to try and build up a therapeutic alliance with these patients, get them on board, get them starting to trust you and trust the information that you're giving them. And we want to make it really clear to patients that it's responsibility here of both parties, that you will play your part in giving the exercises, advice, education, and you're on this journey together. But it's also hugely important that they also take their part within this process as well, and that they take ownership of what's going on. Meller looked at this and said, the pain and self-efficacy seem to be highly relevant in tendinopathy. So if these patients are in huge amounts of pain, they're not likely to potentially adhere. And if they have higher levels of self-efficacy or low levels of self-efficacy, again, the adherence may be impacted upon. So we're going to want to try and drive up levels of self-efficacy if we can, try and get the pain under control, or explain again how the pain science works. To try and increase this adherence to the exercise. There may also be merit in monitoring and screening. So could we start to subgroup some of these patients off? Could we work out exactly which patients may need more of the education and pain science against those who may need more of the exercise? We can modify then our interventions that we do, and we might align our prescription with the education that we're handing out. Some of the tools that we might use to say do some screening or some monitoring is things like the pain catastrophizing scale. And again, I'll give it a minute just for anybody that wants to scan the QR codes to see these will come out in the handouts. We may also look at something along the lines of the pain self-efficacy QR code as well. there for you, and something like the Tampa scale of kinesiophobia, again, which you can then scan and use again with patients. And these again maybe then be applied throughout this treatment process. It's going to give us some lovely information back about where are these patients, how much fear do they have around about movement, how worried are they about, you know, their prognosis, how likely they are to adhere to your exercise, and are we going to have to spend a lot of time, you know, holding the patient's hand as such, but helping to guide them along this path. So what this might actually look like or sound like for our patient, what might you want to think about with some of what you hand out? We're going to want to personalize it as much as we possibly can to that patient. Patients will know if you're going through the motions. So it's going to be important that you think about what is it they want, what matters to them, and how will they actually understand the information that you're going to pass across. How might load management look in their life to them? We might want to think about pain monitoring, and how will they monitor their pain, what their guides will be, what will their anchor points be for them of what's the worst pain of 0 to 10, what's the worst pain, best pain. We're going to need some way of knowing for them, what does that mean to them. We may also, but we definitely want to know is, well, what are their goals? We need to establish what do they want to get out of this, why are they here, and what are they interested in, and what will we again deem success. Winter's a lovely study again looking at Dutch patients, and again what they actually wanted might surprise you. 36% just wanted to return to sport. Lower percentage actually wanted to return pain-free. So what they may be looking for is just simply, can I go back to sport? They just wanted guidance, or, you know, the okay to return, rather than anything else. Some wanted to be pain-free, and then again an even lower percentage want to be pain-free in activities of daily life. So it's important that you find out what is relative to patient, what is relevant to patients, not what you think might be relevant to them. We want to give out exercise that means something. So does it relate to what they want and what they want to do? Somebody may want to simply just go walking to the shops with their friends. They may want to walk around the town. So again, we want to prescribe exercise that means something to them, that they can see why I'm giving this, because it looks like or feels like what I want to get back to do. Can they fit them in? Again, patient adherence will be hugely impacted by the fact if we don't give them exercises they cannot fit into their day, into their hours of their day, around their jobs, their family, again, they're unlikely to do them. Get their input into the exercises. So what do they think about them? Do they think they work? Can they feel them? Do they feel them where you want to feel them? Do they find them too hard? Do they find them too easy? Again, we're going to want to get their input and whether or not they think they can do them. Do they have the equipment, so on and so forth. We're going to potentially want to video these patients doing the exercises. We may want to take pictures on their phones of them. Again, it's going to allow for really lovely feedback, constant reminder of technique and of form, and very often can serve as a reminder to do it again if we set reminders on their phones, so on and so forth. If we are going to educate them around pathology and adherence, it's going to be really important that we check their understanding. So do they understand what's going on with their pathology, and do they understand why it's so important to adhere to the exercise also? It's also really important we speak to them about expectation management. So what can they expect their outcomes to be? What's the timescale likely to be on their outcomes as well? We may want to make sure that they don't start to lose interest or get disheartened quite quickly if they're starting to struggle along with these exercises. If we look at the long term of these patients, and say symptoms may improve between 3 and 12 months, and it could be anywhere within that window for some patients, again, depending on what they come with, depending on the physical state, whether or not, as I say, they're active population or sedentary population. And we know that chronic symptoms can persist in approximately a quarter of patients for 10 years after treatment. Tendinopathy impairs both people's quality of life and their physical activity. So we're really going to want to make sure we get these patients right the first time if we can. And if we don't, and we see this patient after they've seen 5, 6 people, maybe they're 6, 7, 8 years down the line with their condition, we may want to explain to them that if they're still hoping for the day they get fully better and the pain goes, that may not be the case. And that what we're going to try to do is improve capacity, allow them to do things they want to get back to, and again may look just to educate on this idea again that, you know, the hurt may not equal harm to some extent as well. So every journey though will at some point have an end, How long that end may be, or how long it takes us to get there, we don't really know. But how do we know that our interventions actually are having an impact? Simply using, symptoms or what the patient reports sometimes is not going to be enough. So patients come to us in all shapes and forms. What do we use? How do we judge that they're better? And is it our decision on, oh, well, look, you are much better, look at what you can do? Or does it come down to the patient's decision? Habits in 2018 looked at 35 studies, and this was around about return to sport. And so, while return to sport may not be all the patients that you see, it's quite good to be able to extrapolate out a little bit from this and see what do we see in the kind of general population, and how might some of these apply to our general population. So they had 35 studies, 32 of these studies had definitions of return to sport, and only 19 actually had criteria about what returning to sport, or say returning to activity is. So the definitions was pain, was there some pain, was there no pain, was there residual pain? Return to sport might be that people are back at training, they might be back playing full matches, they might just be back at a pre-injury level, or they might be back to previous activity. So again, quite a lot of definitions used. And the recovery, is it safe to return to recovery activity, or is it just simply reduced likelihood of re-injury or new injury? But the summary from the paper looked at, there appears to be a large variation in how return to sport is defined within the current literature, and numerous criteria for return to sport are proposed. And there's a strong need for clinicians and researchers to kind of reach a consensus or a clear definition around about that. So what might we measure? We may look at pain as our measure. We may look at functional recovery as our measure. We may look at muscular strength, range of motion, level of endurance. And again, keep in mind some of these things we're looking at here, because again, as the presentation goes on, we're going to look at what might we be able to use to measure, are our patients getting better, and what judgment calls can we make against some of these? What of these might apply to our patients or your different patient groups? Is it simply that they've completed a rehab program and it's been a progressive stepwise exercise program? Is that enough to say that they are now better? Is it that they've met their individual goals? Is it that their confidence has now increased? But again, within the conclusion, they talk about there's huge, large variation. There's no clear optimization, tough to say, and it kind of limits their usability. So we know sort of this end point is not very clear. We don't really know what we're measuring. The measurements are different for everybody, and everybody has different definitions of what they might want to use. So then again, how do we know these patients are better? How do we know they're not going to have this ongoing problem, or this ongoing symptoms, or this recurrence, or re-injury, or starting to show up on the contralateral side? So this is maybe where we can start to make an impact in our own space or within our own practice. Can we look to assess and measure our patients' deficits better and a bit more objectively? Can we improve our rehabilitation outcomes, and can we have some measurable outcome criteria? So what have we learned up until this point? So the tissue can be overloaded or it can be underloaded. These patients are weak, are very often quite weak across the strength spectrum, and our outcomes actually with some of these patients are not great. Exercise is our current gold standard intervention, and there are various measures of success or various measures of the endpoints. So if we now know all that, what we're going to now look at is we're going to join a patient on their clinical journey and just see how impactful on these outcomes and on these patients the use of good measurement tools might be. So here we have what potentially looks like a kind of standard patient's clinical journey. We have the first part of the chart. If we look here, so we might have this first section up until the first red line, our first red line here. Is that this period of abusive training where they're exercising, not aware of any symptoms at all, but as the time goes on, we may then start to see the first signs of pain starting to appear here. Patient then may only then appear at our door here at this stage here, where they then start to think, well, this is the moment I had my injury, this is the moment that my pain, so it must have been that run that was the problem. They then may then get our input And then within our input, we might start to see this perception of injury come down. We might start to see the tissue damage, I suppose, as such, come down. As we get into this period through rehabilitation, we might try and attempt to return to play, but the pain levels might go up. We may have a few goes, a few attempts at returning to sport, and a few failed attempts, and then eventually we get back to this kind of this healing sufficient enough to get back to normal exercise. And that would be a very classic patient journey we would all see, that they may start this exercise here, 6 to 12 weeks down the line, start to get a little bit of discomfort. They think it was just that run last week where they maybe didn't stretch enough before they ran. And then this, like I say, we see this progressive change, and then we have sometimes this sort of messy middle at points where we're maybe not getting our loading right, maybe they're not taking on board the information we're looking for. And again, without being able to give clear guidelines or clear guidance on, are they getting better? How do we objectively measure? Are they ready to go back to this stage here? Are they ready to go back in here? We may continue to see this as a kind of classic patient journey, but we'd like to think maybe we can improve on that journey further. So if we think of the first stage, or that first bit where they're going through this first stage of just the training, in that training area, do we have the ability then to prevent or maybe even predict who is going to get Achilles tendinopathy, or can we prevent a patient group or a group at large from getting this Achilles tendinopathy? So if we say work with a team, maybe, or if we know our patients very well, if we see our patients regularly, or patients arrive at our doors, we might, first thing we may see is there a change of performance, our first indicator of overload. So if we're monitoring daily within a squad, we may start to notice changes in performance, we may start to notice changes in strength before this patient starts to report any pain whatsoever. And as I say, if we can intervene then, when they are just showing performance deficits and there's no pain, we may then not get, say, the inhibition or the deep-seated changes we saw in the Chang model, where the body starts to show higher changes into the kind of sort of feed-forward or feedback systems. Patients may come in aware that just actually my pace is off, or I can't jump quite as high as I could before, and so can we intervene there? We can't always use pain, or people, the challenge with some of the times with athletes is runners in active populations, they have very low levels of pain-related fear. So they may have been running on for a while with pain and discomfort. And so we can't use pain with them sometimes as our guide. So again, we might want to, in this monitoring stage or this prevention stage, really use performance monitors to tell us that this is now progressing, this is now becoming a problem, rather than actually, no, my pain's the same. Well, large amounts of runners will say, but I run with my Achilles discomfort for years and years and years, it doesn't stop me. But your monitoring might be able to pick, or better monitoring might be able to pick this up. Can we predict who's going to get it? Well, there's one study that looked at pre-weakness, if pre-weakness existed and before the onset of Achilles tendon problems. The study looked at infantry officers recruited prior to basic training, followed them for 6 weeks, and the study reported that around about 50 Newton-meter plantar flexor strength was a predictive cutoff for development, but a sensitivity of 85% and a specificity of 4.5%. So it hasn't really been done again, this study, from what I can see. I couldn't find any studies that looked at this again, and with such a low level of specificity, we're going to get a lot of false negatives there. So it's hard to say, could we predict, can we predict who's going to get it? So we're probably going to be more likely along the lines of, can we prevent rather than necessarily can we prevent rather than predict? So risk factors. So this patient may arrive at our door, or again, we may know or work with a team and we know that patients have some of these athletes within your team have risk factors that may open them up to Achilles tendinopathy problems. We may have a background with the patient who arrives and you've seen over the years for various other complaints, ankles, knees, so on and so forth. So again, familiarity with the group or familiarity with the patient may be the key to what we want to monitor and test. Current literature suggests that risk factors for development of Achilles tendinopathy may include a huge list. So these are all being listed within the research and in the papers. So there's a huge amount of them here, and we're not really going to touch on all of them. As I said, we're going to mostly focus on our sort of active population. So some of the risk factors that we're going to be interested in, or we may use as familiarity, is that recent injuries, or knowing that some of these athletes have had previous tendinopathy. dorsiflexion range of motion, and muscle strength as well, maybe what we're interested in also. As it says, unfortunately, many of these factors are not based really on primary epidemiological data, and they more often than not represent kind of author opinion instead. So again, with risk factors, with systematic review of clinical risk factors, Van der List concluded that from an ocean of studies with high levels of bias, they extracted 9 clinical risk factors that may increase a person's risk. Clinicians may consider oxytocin use, alcohol consumption, and then reduced plantar flexion strength as modifiable risk factors when treating patients. They found that, again, most of the factors they looked at had limited evidence, but the dorsiflexion has sort of conflicting evidence, neither here nor there, right in the middle there. What the world tendon experts say in a Delphi study done with experts, they figured again that muscle strength or weakness was the primary modifiable risk factor for tendinopathy in an active athletic population. And the experts suggest that muscle strengthening may be an important preventative measure. And so again, a focus on measuring muscle strength, power and endurance in a prospective cohorts would give us a level of constitutes a risk appears to merit in measuring this muscle strength, power and endurance as well. So what does our clinical experience tell us? Well, medical experience is that we see a real mix of patients. We'll see some that say with dorsiflexion have too much dorsiflexion. We have some who are very stiff ankles. We may see some that just don't move very athletically as well. But our monitoring and our testing is going to be absolutely essential to be able to keep a check on these patients, to check what their muscle strength looks like, check on muscle strength when they arrive at our door, but also check and potentially monitor throughout their journey as well. So they've come to our door. So these patients arrive, and if you look on the right-hand side on this diagram here, we have tendon health in the middle. These patients may arrive with a sort of mixed bag of all of these symptoms. So they may arrive with symptoms, they may arrive with some pain, they may arrive with some stiffness. They may arrive with noting that they've got a reduction in function, say so jumping or so running, but may have no pain. They may have huge amounts of pain, but no impact on their performance. They may arrive with huge amounts of fear, but actually their calf muscle function looks good. So there's going to be lots of aspects that make up what looks like tendon health. And no two patients are going to be the same. Everybody's going to have different aspects. And again, we're going to want to be very aware that we address these within our assessments with patients, and that we look and try and impact upon as many of these as we possibly can. Within our assessment of the patient, again, if we look back to the other side of the slide, down into here, we're going to want to use a really lovely mix of our clinical reasoning. We're going to want to then, from our experience, we're then going to want to draw on that clinical reasoning from the evidence, but we're also going to want to make sure we use some of these patient values and what they want to achieve, what they want to get out of it, what they deem to be important to them. And that's going to give us hopefully our assessment is a nice heady mix of all of these. So we want to assess them thoroughly. We want to assess exactly where are we now at the start point. And we also want to know what is their goal of their treatment, what might be our exit tests or exit studies, and what we're going to want to test on these patients. What is their goal to get back to? We may want to get their pain under control if they're in high amounts of pain, and that might involve adapting their current loads, so reducing what they're doing ever so slightly to give the tendon some appropriate amounts of recovery to balance this recovery and repair and the wear and repair as we talked about earlier. We may then want to start to progress their loads incrementally again. We're going to be absolutely essential that we pain monitor them over a cycle. We pain monitor over a cycle, and we're going to want to monitor function at set times, so we can continue to keep an eye on just where are we on a performance basis, what impact are we actually having with our interventions, and are they positive impacts, and are they taking us in the right direction? So what might our assessment look like? Well, assessment, if we look at, again, a slide taken from Sports Congress this year and from Van der List, looking at RCT of 25 criteria for diagnosing Achilles tendinopathy. Comfortably, the 3 that came out on top were pain and palpation of the tendon, tendon swelling, and then also pain related to sports or pain related to loading. So if the patient's coming with these 3, we can be reasonably confident that we're going to a reasonably good diagnosis of Achilles tendinopathy. As I say, we're looking mostly here at the active population. I'm highly aware that not everybody's going to fall into that population. So for those who maybe have other conditions or medication-based problems or metabolic disease problems, I'd use this QR code to go and have a look at these tendon questions, which is a really lovely questionnaire that can be used with those patients who we may think may have an inflammatory aspect to their tendon as well. And this is a really lovely questionnaire that I use quite regularly with patients as well. So I'll give you a minute, just I'd highly recommend scanning that QR code to get a nice idea of what you might want to ask your patients to make sure that this is going to respond the way we expect it to respond, and that heavy loading is the appropriate intervention for these patients. So what tests might we run? Well, we might look to do pain on palpation or just a subjective report of pain in that mid portion. And we can see there the kind of sensitivity and specificity of those tests. We may use the arc sign or the Royal London Hospital test. And again, these are good additional diagnostic tests. The arc sign, where again we grip the tendon, we identify any thickened nodules. If thickening is present, the area is lightly pinched, and then when the patient actively dorsiflexes and plantarflexes the ankle, we consider the test positive if we feel that the thickened nodule is moving. If the nodule is not moving and staying where it is, that swelling or that lump may be sitting in the paratendon instead. The Royal London Hospital test, again, we will look to pinch the tendon, find where it's most uncomfortable at rest. We may then actively dorsiflex the foot, pinch the tendon again in the same location, and if there's reduced pain with the palpation, this may again be a positive test. And again, from YouTube videos of both of these tests, so there's a YouTube video for the arc test, again, if you want to scan that. And then the Royal London Hospital test again. Some other outcome measures we want to use with patients is the VISA-A, which is designed to evaluate pain and symptom severity with activity in patients. 8 questions, scores from 0 to 100. 100 indicates no symptoms and full participation in physical activity. We touched upon this earlier, where I think it's led by Murphy, they looked at this and could see that huge amounts of these patients never get anywhere near 100, never get anywhere near above 90, and end up much lower on that scale as well. So again, a really useful scale that we give to patients at the very first session or send home with patients, and then we may monitor throughout the treatment process, and we certainly want to use as some sort of, again, exit outcome measure. Valid and reliable has a number of languages as well, and as I say, around about 10 points is a kind of reflecting a meaningful improvement for patients, but we always want to try and achieve higher if we can. QR code then again for the VISA-A. There's also been a sedentary version of the VISA-A looking to be validated as well for the slightly more sedentary population, and that can be found QR code as well. So we can now move on to the fun part of the testing, but actually it may not be very fun for them. So why are we testing? So evaluating every aspect of tendon health is absolutely vital to evaluating progress, to be able to discuss the patient's goals and expectations, and then making those all important return to activity or return to sport decisions. So we're going to evaluate, we're going to test. What the actual physical evaluation or the other objective evaluation may change. It may look different for everybody. Everybody may have various versions that they do, or they may do it in various orders. This one from Dylan Morrissey is a really nice one, and one's slightly similar to what I would use, where they may look at, say, doing double leg slow heel raises, may look at doing 10, and on that we may comment on form, how good the form is. Do they look like they do the right to left is the same? And we may also look to get a pain score, and at what point and what rep do they get pain. Same may go for single leg heel raises, moving then on to stretch shortening exercises, so increasing the loading going through the tendon, so double leg jumps, single leg jumps, and then some other drop jumps and so on and so forth. And it's going to be here that we're probably going to want to start to see our extension into using some of the convent equipment and how we might use the convent equipment to do such a thing as well. For this assessment, and again, like if you think back to our very early stage, or the early stage in the patient journey we talked about, pre-injury prevention and monitoring, Well, the really lovely thing which we have via the Convent app is the ability to do what in essence is called a fast mode. And that fast mode allows us to make some very quick assessments of patients. So we can see that we might be able to do a really quick, nice muscle evaluation, a quick center of pressure analysis, a quick joint range assessment as well. So we can use the equipment in a very fast, effective way, so that as people are going through training blocks, if patients are coming in to self-test, if we want to do a very quick test at the side of a pitch, at the side of a court, prior to a race or a couple of days before a competition, we can do these really lovely quick assessments as well. That allows us to do some really nice monitoring, maybe some prevention work, and like say some pre-injury work as well. So again, a really nice aspect of using the app. So onto some videos. Let's hope these videos work. So we looked at risk factors, and we also looked at what we're going to be interested in looking at these Achilles patients. So range of motion such as dorsiflexion and plantarflexion. So decreased dorsiflexion range of motion has been identified as a risk factor for Achilles tendinopathy. We also see limitations in plantarflexion range of motion may alter the loading in the Achilles tendon, thereby predisposing athletes to injury. So what might we use? So what we're going to use in essence, or what we use regularly, is the sense, which is what we can see up here. So the sense is a really lovely tool that we're going to use to give us an idea of what our range of motion actually is. So if we look on the list, the video playing now, what we can see is a dorsiflexion test. It's just dorsiflexion test I'm doing in the version of a small knee bend, but we may look to do it in a kind of knee to wall test as well, or whatever way you want to assess dorsiflexion. So what we can see now is what the readout gives us as we use the sense. So it's going to give us an idea of what is the range of motion in that dorsiflexion you've just seen me do. And where we get an idea is around about 27.5 degrees of dorsiflexion available to in that ankle. So with 3 trials. And then what we get is a lovely readout, which will then give us an idea of what do we have as a standard, or what is our average across the 3. We'll then be able to then repeat it on the left-hand side and do a compare and contrast of our right to left, and do we have a dorsiflexion loss of motion. We may want to apply that test again quickly. We may apply that as part of a full assessment, but we may also apply that very quickly at the side of a pitch, or again, the side of a court, to see are we seeing a loss of dorsiflexion after an event? Do we see a loss of dorsiflexion? Or has this patient had a long-term problem with losses of dorsiflexion as well? We can then also monitor plantarflexion. And then plantarflexion, again, we can get up as high as we possibly can with the sense attached down at the bottom here. You can see the sense attached onto my foot. And again, we're then going to go through the same motion as we go up into plantarflexion. It's going to give us our readout on what our level, what our range are. And again, we're going to get 3 trials of this. And again, we're going to, the ability then will be to go back and do left, compare it to right, and what is our difference? Do we see a difference in this? And again, things like this plantarflexion range, for those who maybe, although we're not discussing Achilles tendon ruptures in this video, in this webinar, again, a hugely useful tool to be able to assess, that sort of loss of end range or top range plantarflexion. And again, the graph's going to give us a readout of the three attempts that we had there. So that gives us a really lovely, simple range of motion assessment tool with these patients to see is that range of motion improving as we go through. So we're going to look now at heel raises. So we looked at, obviously doing, say, double heel raises or single leg heel raises, and we may look to score this out of 10, or we may look to do 10 repetitions and get a score on those 10, or what point do they get pain? What does the symptomatic side look like in comparison to the asymptomatic side? Do we see a change in the output, the height they can get, and so on and so forth? So if we look at this video, so again, simple into the plantarflexion. We can then compare and contrast again to the opposite side. All these videos are shot in my house, again, due to COVID restrictions currently. So again, on the setup screen, we may look at, say, repetitions and set repetitions to 10. We may give ourselves a few seconds rest. But again, on that screen, we have the ability then to change how many repetitions do we want the patient to do. And we're going to again see what's the range that they can achieve. So just jump forward into our eighth rep. I'm going to make you watch every single rep that we do. So again, we're seeing now is with every rep, is that range of motion changing? We're then going to switch the sense over to the other side. And again, similar, we're going to be able to see what does the symptomatic or the asymptomatic side do in comparison. The graph at the bottom right-hand side, again, will show us how clear, how smooth the movement looks. Does the movement look juddery? Do they have breaks? Do they struggle to control? And it's going to, again, give us an insight into just what's happening within that muscle group. And again, as we've done our 10 reps, we may be asking the patients for pain scores, but what we're going to get at the end of the readout is what is our score, what was our maximum amplitude, what was the maximum range we achieved, and what do we have right in comparison to left. And again, our graph's going to be there for each rep. So we get a nice ideas. Do they match? Do they start to fatigue off as they went through? So while they may say, I got no pain on that test whatsoever, well, they may not get no pain, we can objectively say, yes, but your range is nowhere near, or the range started very good, but then started to tail off around about rep number 6, rep number 7. So we now have nice objective markers that we can use with these patients to compare to the other side. We may also want to look at jumping, and we talked about a little bit of hopping as well at the start there in terms of an assessment tool. So jumping is essential. So it measures our jump performance, squat jumps, drop jumps, may be useful measures to determine athletic performance at the person level. We see a consistent trend towards reduced explosive strength, between 10% and 21% deficit in patients with Achilles tendinopathy, using rate of force development. Given that rate of force development quantifies the ability to produce muscle force, identifying any deficits may be important when assessing individuals with Achilles tendinopathy, and it's going to help guide, again, our rehabilitation. And we know that explosive strength capabilities are absolutely fundamental during sports movements. For the jumping, we're going to move on to look to using the force plates from Convent, and we use them quite a lot for this. The nice thing about the plates is that we again have the ability to use the fast or the expert mode, so the fast mode again for really quick, nice assessment tool. The expert we may then use as a longer assessment with patients as well, and layer it up with other tests alongside. So for example, in the fast one, we may look to do monitoring post-session. So for example, we may jump at the start of a rehabilitation session to see where we are. We may then do our intervention, and then we want to then see, okay, post that intervention, has our jump height improved? Very often use sort of counter movement jumps, drop jumps and such as morning tests as well for tendon patients as well, to see just what's the pain like the next morning, what's our power output the next morning. Do we think that person can train today? Do we might want to pull them back out of training as well? We may also want to use it to assess and adjust our rehab plan. So, you know, if we bring them in to do some rehab and actually their numbers look quite poor on some of these tests, we may decide that day we're not going to do any stretch shortening cycle. We may do some heavy loading instead. So again, the ability to objectively measure may then tweak and give us a really lovely ability to make sure we are impactful with the sessions that we decide to put together that day. So the counter movement jumps. So again, we step on them plates. What we're going to get a really lovely look readout from is we're going to get our height, our jump height here of just how high we got. We're going to get a really nice readout here of what our strength was and what our left to our right was. We're also going to see down the bottom, we're going to get a rate of force development score, and we're also going to get our newtons as well, so our impulsion as well. So we're going to get a really lovely idea of how much rate of force development did we get, how high did we get, and again, we're going to be able to monitor and track this over a period of time and over the weeks that we're treating these patients as well. Squat jumps. So again, with our squat jumps, very similar. We're going to be able to get an idea of what does our jump height look like. We're going to be able to get an idea of how long were we in the air for. So how long were we actually off the ground. Again, the force on our landing, on our right and on our left, where do we put the force when we land? Are we saving ourselves? Again, our rate of force development down here, and again, our force production as well. So now we're going to single leg movements. So again, through our single leg movements, exactly the same. We're going to be able to compare and contrast left to right. What's our jump height? How long do we actually spend in the air? And similar again, the force, our rate of force development, and our impulsion force again in newtons. So again, really lovely compare and contrast right to left, symptomatic to asymptomatic, or we may even want to try and compare against norms as well. So calf muscle strength, we saw earlier on, it's a risk factor. We also see that these patients very often show themselves to have weaker calves as well. And while we might use some tests, we might use kind of using our eye or kind of a rough objective measure. We really want to address these strength deficits as best we possibly can. Classic one is say calf raise or just simple heel raise tests. But as McAuliffe says, such unidimensional measures to quantify plantar flexion function may hinder the appropriate identification of functional deficits in Achilles tendinopathy, which may lead to inadequate rehabilitation and persistent symptoms. Up here on the right-hand side, we have the handheld dynamometer from Convent. I'm not going to show the handheld dynamometer in this presentation. It is shown in some other webinars. So if you go and look at some of the other webinars on the Convent website, you'll see how the handheld dynamometer is used to measure plantar flexor strength or calf strength as well. But we're not going to show it in here, but it is there and available again as a very fast test, or again as a kind of more in-depth test as well, more in-depth assessment. And then down here we have the length, the strain gauge, which is what we are going to use and what we're going to demonstrate now. So our calf muscle strength. So again, an isometric test. So again, we apply the force through the link. Again, that's then going to give us a readout in kilograms of force. And again, the ability here to compare and contrast left to right. So again, we can assess thoroughly at the beginning of a session, or assess the very first session we see a patient. Where's our strength at this stage? What is our right comparison to left? And then again, how does strength change? And we can track it again through the app to be able to see what change happens as we go along. We can export the graphs, we can export the data, look at it in CSV forms, or look at it on the app itself, and again track and monitor the whole way along. Balance and offloading. So balancing within patients with Achilles tendinopathy. So a study again in 2018 that men with unilateral Achilles tendinopathy have impaired balance on the asymptomatic side. We also know that patients very often will offload the sore Achilles tendon side. They may offload when they're actually doing the test. They may actually offload when they're exercising. Again, those patients we talked about, the athletic patients who have high pain thresholds, may think they're still able to run through their pain or keep running through their pain, but actually we may be seeing problems further up the kinetic chain. We may be seeing them offload ever so slightly. We may see as they start to run, the further they run, do they start to offload more? Do they start to almost limp a little bit but continue to run through? We also see a little bit of offloading in terms of those who are very fearful about movement, or those who have high levels of fear will definitely offload on that side. And Silver Nagel again looked at this and the amount of heel raise work that gets done on this axis here against the Tampa scale of kinesiophobia. So as the score worsens on the fear, we start to see this drop down in the amount of heel raise work they do. So we're going to want to try and assess that fear, address that fear, try to get them to start to take weight onto that right hand side, again using our interventions, some of our education sessions that we talked a little bit about as well. But this tool is really going to allow us to see, are they genuinely making that difference to offloading? And also, as I say, can we assess their balance as well? Similar again, maybe a really lovely way to test pre and post intervention. So pre-session, rehab session, and again, post-rehab session. We may want to test during a session or during a run. Again, the mobility of the plates, so the fact that the plates are wireless allows us to take them everywhere with us, and very easy, quick assessment. And again, that fast mode that we can apply as well. What does the balance look like? So a double leg standing balance. Again, a nice, very quick test. Again, we might do this with eyes shut. We might do this with eyes closed. But what we're going to get again is a really lovely weight distribution here. That's going to tell us again, right to left. Are we offloading the sore side or the symptomatic side? How much do we move, and where is actually most of our weight distributed here as well? Our single leg standing balance. So again, we may want to compare and contrast. Again, left to right. And again, this is going to tell us more this time as whether or not our weight is more on the heel of the foot or on the tip of the foot. Does this person, again, with these sort of central nervous system changes and these body changes, are they loading more away from their extensor mechanisms into their flexor mechanisms? Do they simply just not want to put weight down through that heel? Again, it's going to give us a nice idea, and again, a really nice idea of just where our weight distribution is as well. So again, a comparison of right to left. So as we kind of looked at, or was mentioned earlier on, the kinetic chain have a huge effect on the kinetic chain. And there's huge amount of studies, and it's almost another, again, it's a whole other presentation that can be done to look at what impact up through the hip, up through the knee, up through the trunk that Achilles tendinopathy can have. So again, with these patients, we're going to want to assess, we're going to want to train their kinetic chain, and we're going to want to monitor these changes as we go along. And again, this is where the equipment might come into its own. So we might then be able to look at something like a squat analysis. So the squat analysis is going to give us an idea again of weight distribution. What force are we putting down again through right to left? How does that change as we go along? And again, this is going to give us our maximum strength that we're putting down right in comparison to left. And again, our high and our low. So we can see down here, our high being our concentric force, our low being our eccentric force. So again, when the concentric force to be shift away, concentric phase to be shift away, and the eccentric phase to be shift away as well. So again, some really lovely insight into this kinetic chain. I'm not going to demonstrate hamstrings in this presentation, but what we'll do is we'll look at, again, the link and how we might use the link to assess quadriceps. A lot of theory that, again, quadriceps and calf are very closely linked. Quadriceps, obviously, it can be used is a huge sort of braking force when running, similar to some extent to soleus and gastroc as well. So again, a weaker quad may then again have an impact on calf, or weaker calf may have an impact onto quadriceps as well. So again, a muscle group that we're absolutely going to want to assess in almost all patient groups, whether it be sedentary or active population. And again, our setup for our link is going to be able to give us, again, our force in kilograms that we're applying through that side. And again, we can set it up for as many reps as we want to be able to set it up for. And again, we're going to get our compare and contrast as well. So again, what is our maximum strength? What's right to left? Again, as the rep count goes along, do we see it dropping off in rep count as we go along? If we set up more reps, 10 reps, 8 reps, 15 reps, does it start to drop away on one side comparison to the other side as well? And again, the handheld dynamometer can be used for numerous chain tests in this kinetic chain as well. So that starts to give us an idea of our assessment tool. So what are we doing from an assessment point of view? But we also really want to use the equipment to start to then have a real impact on our rehabilitation. And we talked about some neuromuscular coordination exercises and drills, alongside some just pure strength training as well. So this is again where the equipment is really going to come into its own to be very impactful for these patients in their journey. So we might look at some game-based training. These exercises can be loaded as well. So well, the videos I'm going to demonstrate them is not being loaded, which is body weight. Again, what to appreciate is that these may be loaded up using kettlebells, dumbbells, bars, all sorts of weights, weighted vests, whatever again is appropriate that you're using for these patients. Some of these exercises can be done both in sitting, so with the feet on the equipment, if we're going to be looking to use our bias safe soleus work, or on standing if we're trying to get as much body weight through it as we possibly can. And again, that would depend on the patient population we're seeing, or how much pain they may be in, discomfort may be in. We'll also look at isometrics, again, where we can be loaded, where we can vary the range we're going to want to work in, again with the equipment, or isotonics, again, where we can make load. We may want to change the rep range or the set range we're going to work in, or vary the rest period. So just are we working on endurance? Are we working on power? Are we working on speed? Are we working on max power? And so all these different rep ranges and sets that we may want to use, and so how the equipment again allows us to test, and how it then is used to be able to actually treat and prescribe exercise alongside. So the strength training, so this is again quite neuromuscular based training we're going to look at. Again, on the app we have the handheld dynamometer here for again being able to use for ankle extension, for plantar flexion, and again just an idea of what the kind of sort of games we can play with this. So here you're going to get a wee video. So this initially is going to look a little bit boring to some extent in terms of that what you can actually see movement wise, but it'll become a bit more clear when the video changes to show us just exactly what we're doing. So far we've got a change of direction, or a change in weight balance, change in weight transfer. We can go up onto our toes and we can do our weight transfer. So we're having to control the range we're working in. We're having to keep our heels off the ground. We're going to get a nice idea of it as one heel starting to drop. Where do we feel fatigue? Where do we feel tiredness? We can then work again at different knee angles, different plantar flexion angles. And again, we've got huge amounts of control required in this exercise. And we might be able to then drop down back onto our heels, really working through that soleus. But the soleus's job obviously being, having a big role to play in terms of when the foot's flat on the ground in mid-stance, and controlling the shank movement in comparison to the foot. So again, getting down onto that heel, bringing that knee over those toes. Then again, some lovely control involved to try and change where our weight is distributed. So huge amounts of calf work, huge amounts of Achilles work going on. So within the app, we can change whether or not we want to work on our weight distribution going forward or back. We can work on our weight distribution going left to right. If we want to force the person to put more weight on the left, we may change the setup so we can now force them onto the left-hand side a little bit more. We can also then set how difficult we want the exercise to be for them. And so now if we think back to what we just saw in terms of the movement I was doing, we may now be looking to go left. We might be forcing this person to try and get to the ball using the kangaroo. So they're moving left, they're moving right, they're changing where the center of pressure is, but they're also having to learn to take more weight onto this left-hand side, all while making it quite a kind of cognitively rich rehab, process. Makes it fun, maybe builds them in some adherence as well. We may now be doing this on our toes. So as the video showed you, we might now be on our toes and going left to right. And again, keeping our heels off the ground, but again, getting that loading up onto that left-hand side. We may go forward and back. So now we can really work on that kind of plantar flexion, bringing our heels down, raising our heels off the ground. So really lovely amounts of fine control, lots of lovely joint position sense work. Lots of lovely isometrics, straight into some isotonic work. And as I say, we might be loading this exercise up to make it, again, even harder within the rehab process as well. So now we might look at some isometrics. So again, isometrics as an exercise has had a lot of attention in terms of tendons and the use of isometrics within pain control and inhibition and being able to bring down pain to then allow performance straight away. But as an exercise choice, it's a fantastic exercise choice in the early stages for patients who maybe have some fear about movement, so it doesn't involve any movement. And again, it can be used both in an active population and our sedentary population as well. So how do I set that up? So this is again what the isometric is going to look like. So we may then use training. Our protocol that we've established, we're going to look at isometric. So within our isometric, we may then decide that we want to work at a certain range level, so we can set our range level. We may also want to decide we want to work at a certain percentage of our range, so the system knows what our maximum range was. So it's kept a note of what was the range that that patient was able to achieve when we did the testing earlier on. So they know what their maximum is. We may decide we want to work at 75% of their full range. We want to work at the very top end of their range, but midway or halfway, maybe we want to work just outside where pain came on. So again, we can set the system up so that when we then know how long we're going to be there for. We may also want to set it up that we're going to get them to hold that isometric for a long period of time, 30 seconds, 45 seconds, so on and so forth. I've set it up very short period of time here just so we can, for the video, but we can see the small green bar at the top. That's where we're trying to get the person to get to. That's the range we've set for them. And we're going to try and get them into that isometric range. And can they stay there? So can they maintain that quality of the rehab drill that they're doing? Again, we'll switch it over to the other side. And now we've made that window a little bit bigger. And again, we're going to look for them to try and stay within that window. What's their error like? What's their joint positioning sense like? Can they stay there for 30 seconds, 45 seconds? Might we load that range up? Might we put enough body weight on it or enough weight on it to get the impact we're looking for? And by changing the range we're going to work in, we may work at a very early range of plantar flexion. We may work mid-range, end range. We may want to work from our assessment. We may know where they look like they really struggle to get into. And so that might be where we want to work for these people. And again, it will tell us what the success rate was of staying in that window. So can we monitor that success rate? Does that success rate improve? Are they all over the place, all over the graph initially, but as the weeks go on, do they start to level that off as well? And again, a really useful tool for those Achilles tendon ruptures, or again, the acute ones that maybe we are using isometrics as our option. So isotonics and our kind of rep count, as it's called on the app. So again, this is just going to be our standard training-based exercise that we're interested in. So our calf raises, all the different variations of exercises that we may play around with. And we're looking at our strength profile. We're going to look at our power, our max strength, our endurance numbers. And so we're going to set the system up to allow us to set the exercise levels for them. So as they're doing their rehab, we're going to get quality every single time, and we're going to get the changes we really are interested in. So again, that's what the isotonics obviously look like. Again, this is body weighted, but again, we may set it up through training into the sense, the protocol that we've set up. And again, you can set up your own protocols. So again, within this, we know what the 100% is. So up here at the top, we know what the 100% was of the range that they are able to achieve. So we may decide that we want to set up, that we want them to get to the full range. We may decide again, we want to work at a certain level of range. We may know what the percentage of force we want them to apply. We may set up our range, our rep count to be, let's say, 10 reps, 3 sets of 10. We may 4 sets of 8. We may vary the sets and reps. We may look to also vary the rest. We might want them to rest for 2 minutes, 1 minute. And again, this will allow us then to be able to test. So our repetition counter then gives us the ability to say, okay, so did we get above the range we're looking at? So do they get up to the height we're looking for? Is every rep a good quality rep? The red line that we can see appear as well at the top as we go along is going to be the pace. So are they able to maintain a good pace? Is the pace consistent? Does the pace drop off? Do we want them to work at a specific pace? So if we're looking to work power or speed, do we want that number to be higher? Do we want them to stay very high so every rep is as fast as it possibly can be? So again, this could be a heel raise exercise as we demonstrated. But again, the ability to compare right to left, but make sure that the actual training is high quality, the force is where it should be, and that we're not cheating on any reps whatsoever. Again, we've got the ability to look at the pace that we're able to get to that range at, the success rate of getting, again, do they start to drop off? What's left in comparison to right? But then also, can we compare right as we go along through our rehab process as well? So everyone's journey may, however, differ, and how they get there and what we prescribe using this equipment as well. We want to be very patient-centered, that patient in front of you is not going to get just a standard rehabilitation program. They're going to get a program that's developed and designed really for them. So for our younger active patients who maybe have good strength already and have high load demands, we may use isometrics, but we may go straight on to the rep count type exercises. With the eccentrics, we may go straight on to look at the power, and again, using the plates to judge that power and that output. For our middle-aged recreational, who have reasonable strength, but maybe lower demands, just starting out an exercise, restarting exercise, again, we may look to use isometrics, we may use the eccentrics, we may be a bit more interested in strength endurance with them as well. And again, we may want to set up their exercises related to strength endurance. And then our older sedentary patients, we may simply use isometrics. They might be a bit more weaker. We're going to start off potentially, like say, with our heavy loads, before we might move on to some endurance, before we also might move on to some speed as well. And again, down here, we can see a little bit of how that might vary. So in our very high activity group, we may spend a very short amount of time here doing some isometrics before we move on to some concentrics, some eccentrics, our heavy loading, our speed and our impact. So we may move through these stages very quickly in our rehabilitation, where we might spend a little bit longer in each phase with these groups here. But again, the ability here is to be able to track them and see when do we think it is appropriate that they now move on to that next phase. The key here really with rehabilitation is that we want to make it as cognitively rich as we possibly can. We want to make it as interesting as we possibly can. We may do that, say, via the use of maybe some music, get them doing their exercise to music. We might use a metronome along the lines of sort of Eddie Rio's work. Again, can we impact on just how much they're engaged with the exercise, how much they focus on the exercise, their adherence and the quality of what they do. We might use some blood flow restriction or blood flow resistance exercise. And again, that's another talk altogether. We may have them do it with their partner or someone alongside them, again, to try and drive that adherence or drive a goal or drive a competition to some extent. Some patients, we might have to address their biomechanics. How do they run biomechanics? Do they run with lots of dorsiflexion? Do we want to reduce that? Maybe we want to increase their cadence, reduce their cadence. And again, these are all going to be very patient-centered. We may also want to remember that when we're doing all this work on their calf, we may also want to look at improving their athletic fitness in general. So we're giving them out not just some calf-based exercises. We might be looking to hand them out some trunk-based exercise, some upper limb exercise. We may have them working hard on the bike if they can't run. We may have them on the rower. Again, we're going to want to take these patients and develop them as an athlete or develop them as a person physically alongside while treating that aspect. And then we had the adjuncts that we talked about in terms of the other interventions, orthotics, taping, so on and so forth, that we may decide to use as well. We do have a slight interesting fork. I know that in this year where we've seen a really fantastic paper come out from Baxter, where they sort of shifted the needle a little bit in terms of what do we think about when we're going to prescribe exercise, and slightly moving away maybe from this kind of calf raised sort of centric approach a little bit. So they used three-dimensional motion capture and some ground reaction force data to estimate pardon me, Achilles tendon loading biomechanics. So they developed an exercise progression that incrementally increases the load in the tendons based on the magnitude, duration, and the rate of tendon loading. They did it by establishing progressions for Achilles tendon loading, rehabilitative care, and can be tailored to address the specific needs of each patient. So they did that by calculating 3 parameters of these exercises. So they calculated what the peak tendon load of an exercise was, so the highest force that went through it. They looked at what was called loading impulse, which was the kind of cumulative loading applied to a tendon. And then they also looked at a loading rate, and we can see down here, so we have peak loading here, the loading rate here, and then the kind of loading impulse all together there. And then using those, they then ranked the Achilles tendon loading by exercise with a loading index between 0 and 1, with 0 representing no tendon load and 1 representing the most tendon load. So oh, we've lost the graph. So the graph is gone, but in essence, within the graph, what the graph then tells us is there are different tiers of exercise. So, for example, we may look at an exercise or a tier of exercise that has, say, a double leg heel raise, but that loading index of that double leg heel raise may also match the loading rate of, say, a high step up or a low step up. So that the index, then you may decide that, okay, well, this patient may struggle to do a double heel raise, a double heel leg raise, but they may actually be able to do a high step up or a low step up. And the Achilles tendon load within that exercise may actually match that. So we're able to match what would be single joint loaded exercises to multi-joint loaded exercises, which might then be easier for a certain population or certain patient group. Or if we're thinking about combining, again, from an athletic development point of view, we might add 1 or 2 Achilles exercise or single joint Achilles exercises in, but we may want to continue to load the Achilles within a wider program while also building up strength in the kinetic chain. So we may then look to see what is the strength index or the Achilles load index of, say, a lunge, or with on the foot at the back or the foot at the front, or a double leg hop. And it gives us the ability then to make some differentiations between which exercise is most appropriate and how might we approach exercise slightly differently. And there should be a chart there on that page, but it will be in the handouts. So what is actually in our bag as a rehabilitation tools? What can we use for rehabilitation? And what might the exercises we might look to prescribe? This is not going to be a kind of huge amount of exercises we're going to demonstrate here. This is just a small selection. But what's going to be really important, though, is form to some extent. So on this picture on the left-hand side, on this picture here, looking at some of the work that's coming out of Australian Ballet, where they're looking at calf strength and injury prevention within calves and ankles within that populace. The important thing is going to be form within our exercise. So this vertical line here, what we're going to want to do is as patients go through these exercises, we're going to make sure that this line lines up perfectly well around about toe 2 or 3 with the middle of our knee, and that we're not starting to see this knee drift out to the side. So what we might then be doing is we then might be working one side of gastroc and underutilizing the other side of the gastroc as well. So again, we're going to want to make patients aware of the quality of the exercise that they are doing and where their distribution of their weight is. We also want to make sure that as they go up, that they're weight bearing through all of the toes, that again, the base of every toe is down, and we don't see these patients go up onto the outside toe 3, 4, and 5. We want to make sure we're not seeing too much drift outside of this hip. Again, we might demonstrate a little bit of weak glutes alongside or lateral hip musculature. And we also want to make sure, again, that we're not seeing this pelvic drop up here anywhere alongside here as well. So again, some numerous kind of teaching points we want to be very aware of. So again, we're going to get real impact on what our outcomes are going to be. This is also a good opportunity to work foot intrinsics. So we might use foot intrinsics where we might look at, say, doing exercise like doming the foot. We might look at working that, driving the base of that big toe into the ground and using some of our toe long flexors and extensors. And we might want to try and make sure that when they're going through some of these Achilles exercises, where possible, they're working on these foot intrinsics to try and strengthen that up, try and make that foot ankle kind of calf complex stronger, more robust, and more like a spring. We also want to absolutely make sure that when we're going to make them do exercise, is if we're looking to get vertical loading, they truly are going vertical, they truly are going upwards. And if we're going to eventually in time look to make them go kind of in a diagonal plane, that they actually are going in that plane of movement. So make sure that we really have an understanding of and check and say using a mirror or using a video or again pictures, that they truly are loading in that vertical plane, or any other plane that we're looking to work in. So what do we have to be able to use? So we might look again at seated heel raises, for example. In that seated heel raise, we've got the sense on here, so we can monitor again using the sense of just how high are we getting? Are we getting good reps every single time? Are we hitting the marks we want to hit? Have we put in a range that we want to stop them at? And again, we might do some seated heel raising. Again, this is unloaded at the moment, but this may have weight on it. It may have a sandbag, it may have a Smith machine, it may have a calf machine, it could have a dumbbell, it could have anything that we're trying to load these people up with. But again, using the sense is going to give us the ability to make sure every rep is quality. Same again, using the force plates. We can use the force plates again if we think back to what we used them for with the kind of neuromuscular control exercise. We might use some neuromuscular control where we go forward and backwards, move from our toes onto our heels. And again, we can work a little bit on some of those isometrics as well. So using the sense, we might look at the isometric force, what range do we want to hold in, what range do we want to work away at. So into some isotonics. Nice straightforward calf raise. Again, we might have this loaded, we might have this on with the sense. We might then look to work different knee angles to try and again work a little bit on this control and the coordination between gastroc and soleus. And again, we're going to make sure we're getting nice vertical height. Again, with the sense on or with the plates in place, we might be using this as an isotonic exercise or an isometric exercises. We might now look to use changing the plane we want to work in. Now we start to move into really using the rest of the chain to some extent. Really asking a lot of soleus to contract, and again on that concentric and then down into our eccentric. We might look to change the speed of this as an exercise. Again, this all may be loaded up in various forms. We might now look to do some faster contractions, some rebounding heel raises. We may look to move fast on the concentric, fast on the eccentric. We might need to change the rate, again, for some coordination. Again, some more explosive work. So really working that soleus and then really exploding. So really using that soleus to control that shank and then really, again, exploding off that foot. And again, we might use our equipment to tell us where do we start to fatigue? Is our power output improving? Is our range good every single time? Are we really getting to the end and really using the best of that calf to give us that push off, say for our sprinters or our more athletic group? We might look at some very simple plyometrics. But again, this stretch shortening cycle, we're not letting the Achilles really change much in the way of length. So this might be a very early stage sort of hopping plyometric drill or jumping plyometric drill front to back. We might increase the speed of that as an exercise as we start to be able to do that. We've got some nice continuous double hopping. We've got hopping in holds. We've got hopping from 2 to 1 on the other side. We might do some side hopping, again asking a bit more of that musculature, try and get that. We might do deeper hops, so we might look to really get that sort of knee involved, kind of much more kind of kinetic chain exercise rather than the spring aspect. We might do some weight transfer, keeping the heels up. We might go backwards and forwards with that weight transfer. And again, we're really looking to get this muscular tone appropriate for what we're trying to do. Again, if you think back to that Chang diagram with that sort of change in levels of force, is the appropriate force we're putting down? Do we have the control that we're interested in? We may look at some more plyometrics. So we go from 2 to 1. We might go from 1 to 1. And again, within those exercises, we might make that 1 jump, we might make that 2, 3, 4, 5, 6. So ever increasing levels of jumping as well. So by no means what I'm showing here is a sort of map that they say there's no sort of recipe to this. It's just a sort of a very rough guide of what we might look at with, say, a patient potentially. We might look at, again, the early sessions or the early days just being sort of education, getting the idea of how to use, say, the diary they may use, like for the pain scores, for the pain monitoring models, how they're going to diary their stiffness, diary what they did that day, get an idea of what their activity levels have been, what their pain scores are. We may use the isometrics in the early stages, whether that's been sitting or standing. We do 45 seconds using body weight, 5 lots of 45 seconds potentially. And again, this is where, again, our equipment's going to come in to make sure that the quality's there, that we set the system up to do 5 lots of 45 seconds, both in sitting and standing. If we've had good pain or good exercise adherence, we might move on to sort of, again, reflecting on their diary, having a look at the diary with the patient. We may still, again, be having them do isometrics daily, but we might look at some of those functional exercises that I talked about, but the chart didn't come up. But we might look at some of those lower functional exercises, start to build now into a bit more kind of whole body, whole kinetic chain. We might move into the world of isotonics 3 times a week, maybe some sitting heel raises. Again, we might use an RPE scale for that to get a judge of how hard does it feel for them. 6 to 8 reps per second, 6 to 8 seconds per rep, sorry. We might introduce some control-based exercises again, like we've looked at again with the neuromuscular control. Similar again, isometrics, ever-increasing weight on our isotonics. We might now start to introduce some stretch shortening cycle exercises as well. We may also then look to start like a little bit of work on, as we move further down the line, again, some continuing to do, if we have had no reaction to our introduction of strength shortening cycle, continue to do our isometrics daily, maybe starting to move into the harder functional exercises, the ones that have maybe a slightly higher load force as well. Isotonics, again, increasing weight through isotonics. Continuing to work harder now on our stretch shortening exercises, so going to our continuous jumps, maybe onto some higher box jumps, some plyometrics, looking at some step squats, some double leg to single leg again, single leg to single leg, and again, some other single leg type jumps. As I say, this is not really a recipe, just a rough guide to how we might increase or challenge these patients as they go along. So how might we chart the journey? So we're going to chart the journey using various scales or pain monitoring model. We may use for 0 to 2 is an acceptable level of pain and discomfort. Somewhere between a 2 and a 5 might be acceptable as well. But we're going to want to get an idea of where does the patient sit in this pain monitoring model. What do they score in the mornings? What do they score after certain activities? We may use a Borg scale of RPE. And again, get an idea of just how hard do they find in their exercises, how hard do they find their overall day of exercise, how hard do they find each individual exercise as well, so we can start to scale our exercises against what they perceive to be difficult, what their pain scores look to be as well. We may also look to chart their week against what they deem to be light tendon activities, medium tendon activities, or high tendon activities. What pain levels might be allowed during those windows as well. How many days rest we might look to put in place for those. Again, when we think about this collagen synthesis and degradation, what they deem to be an RPE. So again, we can really chart the journey for these patients using various models and various scales, which is really going to give us the ability to see just where are they, how have they improved, how have they changed, and are they where we expect them to be in their rehabilitation phase. So the evidence would suggest that during the rehabilitation process, any worsening of swelling, any morning stiffness, maybe delayed onset of pain, we need to closely monitor and control, as this inflammation could drive the tendon further down the pathological path. So we're really going to want to monitor what are we doing exercise-wise, how is the patient finding the exercises, and what's the impact that it's having on the patient. So finally, some recommendations. So the important part is that the one size fits all method of assessing and rehabilitation patients really fails to adequately address all the deficits, not only in maximal strength, but potentially throughout the entire spectrum. We might want to look at using something like a Visa A as a guide for our return to sports. On some of those tests that we've looked at, Silver and Eagle has kind of put out there that we might want around about a limb symmetry index of 90%. And again, using the equipment that's going to give us the ability to judge that alongside and see whether or not at the end of a rehabilitation program, do we have that on a lot of these tests. We might want to do some psychosocial screening, psychological screening, as we already kind of alluded to. We're going to want to monitor these patients very closely and get much patient buy-in as we possibly can. And then we might get that patient buy-in via the monitoring as well and get them to take responsibility along those lines. We want to use as much heavy loads as we can, we want it to be as progressive and also have an element of control, and that rehab is going to be nuanced, especially nuanced, and not going to be the same for every patient. Patience is going to be key. As I say, well, we may see improvements in 2 weeks. This may take some time, and it's really important that we have open, honest conversations, and they really are essential. Final recommendation is stay safe out there just now. As I say, it's an interesting world that we live in, and hopefully you all found this to be very interesting and useful information. Good luck to those who are also working from home. As you can see in these two pictures, putting together this presentation has had its challenges and its highlights and its and some happy moments as well. But yeah, it's a challenging situation we all find ourselves in as a profession in general and for individuals as well. So finally, just to say thank you to Convent for asking me to do this. You can find out more information about our business, our Project Physio. And I say I can't highly recommend enough the Convent tools, the Convent equipment, which is really impactful, hugely kind of game-changing, rehabilitation changing, and the potential for using these bits of equipment is huge. So thank you very much for watching. Hopefully it hasn't been too long for you, and best of luck to everybody out there, and thank you very much.